Compression therapy consists of applying a compression device around a body segment to exert an external pressure. Several compression materials can be used for compression therapy. However, all of them can be distinguished in inelastic and elastic materials. Elastic materials include elastic stockings, elastic kits made up of 2 superimposed stockings, and elastic bandages. Inelastic materials include inelastic bandages, adjustable compression wraps, and pump exerting an intermittent pneumatic compression. Compression pressure is a deciding parameter of compression therapy. It can be measured in the supine position, supine pressure, in the standing position, standing pressure, and during muscle activity, working pressure. According to a past consensus document, the supine pressure has been defined as light, below 20 mm of mercury, moderate, between 20 and 40 mm of mercury, strong, between 40 and 60 mm of mercury, or very strong, more than 60 mm of mercury. Light, moderate, strong, and very strong pressure must be applied according to different clinical indications. A light, moderate pressure is enough in the early stages of chronic venous and lymphatic disease, such as symptoms and edema control, and in the maintenance phase of more advanced stages, such as a healed ulcer or lymphedema maintenance phase. A strong or very strong pressure is necessary mainly in the venous leg ulcer treatment and in the lymphedema treatment phase. Stiffness is the other important parameter of compression therapy. According to the European Committee for Standardization, stiffness must be defined as the pressure increase produced by a compression material per 1 cm increase in the limb circumference. Professor Parch proposed simplifying the calculation of stiffness because simultaneously assessing compression pressure and limb circumference increase by standing is impossible in clinical practice. He suggested that muscle increase when moving from the supine to the standing position should always be 1 cm. In this way, stiffness is simply the difference between standing and supine pressure, and all the interested clinicians can easily perform its calculation. He named this parameter the static stiffness index. Based on multiple tests on elastic and inelastic material, it has been stated that when considering the static stiffness index, 10 is the cutoff to distinguish between elastic and inelastic materials. All materials with an SSI lower than 10 are elastic materials. All materials with an SSI higher than 10 are inelastic material. In this slide, we can see that a long stretch bandage and a round knit elastic stocking have an SSI lower than 10, while Una boot, short stretch bandages, and class 3 flat knit stockings have an SSI higher than 10. All this is true provided the materials are correctly applied. Actually, a loosely applied inelastic bandage can have a very low static stiffness index, and an elastic bandage applied at its maximal stretch can have a high static stiffness index. Stiffness is important from 2 points of view: compression effectiveness and comfort. Indeed, an ideal compression device should exert a pressure close to 0 mm of mercury at rest, which is very comfortable, and 80-90 mm of mercury in the standing position to overcome the intravenous pressure and exert its hemodynamic effect. Only in elastic devices, you can see CoolFlex here, an adjustable compression wrap, are close to an ideal compression device. An inelastic material like CoolFlex can exert high pressure by standing, 89 mm of mercury in this case, and even higher pressure peaks during physical activity, higher than 100 mm of mercury, starting from a significantly lower, comfortable supine pressure of 49 mm of mercury. This intermittently strong pressure can overcome the intravenous pressure and restore a kind of valve mechanism. In this way, inelastic materials are hemodynamically effective. The same is impossible with elastic materials, which usually exert a low pressure with a minimal pressure increase by standing up. With an elastic stocking, you may have a pressure between 15 and 45 mm of mercury, depending on their classification, with a low stiffness. In this case, the elastic stocking exerts a pressure of 29 mm of mercury with an SSI of 7.4, so the standing pressure is only slightly higher, 36 mm of mercury. With the two superimposed stockings, the baseline pressure is higher, 44.6 in this case, but the elastic characteristics are more or less the same, SSI 5.4 and maximal pressure of 50 mm of mercury. These materials do not exert pressure peaks and never overcome the intravenous pressure. Their hemodynamic effectiveness is low. On the other hand, when using elastic material, it is necessary to consider their elastic power, which is the force to resume their initial length after stretch release. The more elastic materials are stretched, the higher their elastic power. For this reason, elastic material cannot be stretched too much or exert too strong supine pressure. A supine pressure of around 40-45 mm of mercury is the maximal pressure for elastic material to be tolerated. It is also possible to overcome the intravenous pressure with elastic material, but due to their low stiffness, applying a very strong pressure also at rest is necessary. This can be done by superimposing several elastic stockings or wrapping elastic bandages at their maximal stretch. Unfortunately, this continuous strong pressure at rest and during standing and walking, combined with their elastic power, makes the compression very painful, which cannot be tolerated for a long time. In conclusion, stiffness and pressure are the most important parameters for compression therapy, and they are different for elastic and inelastic materials. Elastic materials should exert low to moderate pressure with low stiffness and have a light hemodynamic effect. Inelastic materials exert a strong to very strong pressure with high stiffness and are very hemodynamically effective. These differences are obviously reflected in different indications for compression materials. The elastic material is the most extensively used, and it is used when a significant hemodynamic effect is not requested. From C0S to C5, in small and recent onset skin ulcer treatment, in post-thrombotic syndrome, after thermal and non-thermal ablation, in lymphedema maintenance phase, elastic stockings are the only used compression materials. Inelastic material has more selective indications and must be used when a significant hemodynamic effect is necessary. In skin ulcer treatment, in the acute phase of superficial and deep vein thrombosis, in the lymphedema treatment phase, and after venous surgery. It was a pleasure having you here.